Hello everyone, welcome you all to the fourth session of Movement Maestro Academy of this year 2022. For today's session, we have our resource person, Dr. Divya. On this session, we are going to discuss on arthritis. Without wasting our time, let's start for today's session. Over to you, Dr. Divya.
Yeah, good evening, everyone. Yeah, is my slide visible to you?
Yeah.
Okay, so for today, our topic is arthritis. I'll be starting it with the definition. So the word arthritis is derived from Greek, where arthro means joint and itis means inflammation. So it's a combination of two words, arthritis, arthro and itis. So it's basically a joint disorder, which is classified into first category, that is inflammatory and non-inflammatory. The inflammatory is rheumatoid arthritis, commonly known as, and non-inflammatory is osteoarthritis. Another classification is monoarthritis and polyarthritis. Mono means involvement of only one joint. Mono, one. Arthritis means inflammation of joint. So poly means more than two joints are involved. So that is known as polyarthritis. So monoarthritis, it can be pyogenic, tubercular, hemophilic, secondary to osteoarthritis and gout. The polyarthritis can be rheumatoid arthritis, rheumatic fever, juvenile chronic polyarthritis. Juvenile means in children less than 18 years, and primary osteoarthritis and seronegative spondylitis. So we'll be starting with rheumatoid arthritis. These are the main common arthritis. So rheumatoid arthritis is a chronic non-suppurative inflammation of the synovial joints, which is chronic, and inflammation of the synovial joints. All the synovial joints in the body, inflammation occurs there. Age of onset is typically 20 to 40 years. So any person complaining of pain in joints and signs of inflammation between 20 to 40 years, so we can consider is that rheumatoid arthritis. Etiology, it's an autoimmune disease, but the whole etiology is unknown still. Following factors have been thought to play a role in the causation of disease. First is genetic predisposition. Second is agents such as viruses. Genetic means uh, uh, genetic disorder, and agents such as viruses are involved. Third, it results from exposure of a genetically predisposed individual to some infectious agents. This leads to autoimmunity and formation of immune complexes with IgM antibodies in the serum. These immune complexes are deposited in the synovial membrane and initiate a self-perpetuating chronic granulomatous inflammation of the synovium. Once the antibodies are generated against the synovial membrane, it keeps on increases and start the inflammation of the synovial membrane. So in this diagram, we can clearly see how does a normal joint look like and a rheumatoid joint look like. In a normal joint, we have a synovial capsule and lining, which is normal. Synovial cavity is normal. Cartilage is also normal and healthy. In rheumatoid arthritis, the bone and cartilage erosion starts and increase in synovial fluid. Because of the inflammation, there is a swelling. So there is an increase in the synovial fluid and the pannus formation is there. This is the pathophysiology of the rheumatoid arthritis. Once a foreign antigen enters the body, CD4 plus cells, T cells are secreted, and then there is an activation of B cells and T cells, which initiates an hyperimmune response in the blood, which forms the immune system complexes. Then there is an activation of macrophages, which initiate a inflammatory process. Then interleukin 1 beta, interleukin, and these factors are released, which results in pannus formation. Then there is an activation of endothelial cells, which leads to an increased expression of adhesion molecules, and inflammation matrix cells start accumulating in the joint. These all together increase in the pannus formation, which leads to rheumatoid arthritis. With the diagnostic criteria, how do we diagnose that diagnose that it's an rheumatoid arthritis. So there's a new diagnostic criteria for rheumatoid arthritis by American Rheumatism Association in 1987, which has 7 factors. First is morning stiffness. There will be a stiffness in the joint early in the morning, which is known as morning stiffness. Then swelling of 3 or more specified joint. There is a swelling in the joints because of the increase in synovial fluid and inflammatory reactions. Swelling of joints in the hands and wrist. Particularly small joints are involved. So there is a swelling of joints in the hands and wrist. Symmetrical swelling, that is, there will be swelling in both the hands if the joint is involved. Then there will be a rheumatoid nodule. Rheumatoid nodule is a nodule like swelling will be there. So that will lead to formation of a nodule. You can clearly see that with the naked eye. Then there is a rheumatoid factor positive. When we'll be going for blood investigations, that time we'll be having a positive rheumatoid factor. Then X-ray changes. In X-ray will be clearly visible erosion of the unequal periarticular osteopenia. There will be an erosion of joints, just as we found in that previous picture. If 4 or more of these are present, then it is rheumatoid arthritis. The above factors which are there, out of 7, if 4 or more are present, then we'll be concluding it as rheumatoid arthritis. Another, there is a revision of the classification by the American College of Rheumatology, and they have classified into 4 classes. The first class is completely able to perform usual activities of daily living, self-care, vocational and avocational. The patient is able to perform every activity of his daily living independently, be it be of self-care, that is bathing, eating, vocational, the work related work, and avocational means other activities. Class 2 is that able to perform usual self-care and vocational activity, but limited in avocational activities. Other than his own work and self-care, he won't be able to perform the activities, or which will be limited in nature. Class 3, able to perform usual self-care activities. The person will be able to perform his usual healthcare activities, daily activities, but the vocational and avocational, both the activities will be limited. And the class 4, limited in ability to perform usual self-care, vocational and avocational. All the 3 activities will be limited. Then stages of the rheumatoid arthritis. From clinical point of view, as a clinician, rheumatoid arthritis will be able to divide into 3 stages. First is potentially reversible soft tissue proliferations. In this stage, the disease is limited to the synovium. There occurs synovial hypertrophy and effusion. No destructive X-ray changes can be seen. Means the degeneration is there only in the synovial part, not in the bone. The second is controllable but irreversible. We can control the disease, but we cannot reverse it back. Controllable but irreversible soft tissue destruction and early cartilage erosions. X-ray shows a reduction in the joint space, but the outer line of the articular surface is maintained. There will be a slight reduction in the joint space will be seen in the X-ray. That is why it is irreversible in nature. Once the joint space has been decreased, we cannot reverse it back. Bony changes, whichever are occurred, we cannot reverse it back. The third is irreversible soft tissue and bony changes. Now there has been changes in both the soft tissue and bone, irreversible in nature. The pannus ultimately destroys the articular cartilage and erodes the subchondral bone. The joint becomes ankylosed and usually there is a deformed position. Once the joint has been alkalized, means fused, or any deformity is there, that is irreversible in nature. It may be subluxated or dislocated. Subluxation means there will be no uh, connection between the 2 bones, and dislocated also. So here it's very clearly by the figure. First is early stage of the arthritis, only the synovial membrane is inflamed. The second stage, both the synovial membrane is also inflamed and the bone space has been, joint space has been narrowed in nature. And the third, the joint has been subluxated or dislocated in nature. So all the 3 stages we can clearly see in this figure. The next is diagnosis. How do you diagnose that it's an rheumatoid arthritis? First will be the clinical features, the features which we are able to see. The clinical features will be occurring in between the age of 20 to 50 years. As I earlier mentioned that any patient complaining of these clinical features between the age of 20 to 50, we can suspect it as rheumatoid arthritis. Women are generally more affected commonly than men, that is 3 times. So the joint affected in rheumatoid arthritis are the most common joint affected are carpal phalangeal joints of hand, PIP joints of hand, that is proximal interphalangeal joints, wrist, knees, elbow, and ankles. The less common joints which are affected are hip joint, temporomandibular joint, and the uncommon which are least affected are atlantoaxial joint of neck, that is for C1 and C2 vertebra joint, and the facet joint of cervical spine. So these are the clinical features. If these joints are involved, we can suspect it as rheumatoid arthritis. So now on examination, we'll be seeing swollen bogey joints as a result of intra-articular effusion. The joints will be swollen in nature because there has been effusion in the joint because of the inflammation. Synovial hypertrophy will be there and edema of the periarticular structures. Joints of the hand shows typical deformities, severe muscle spasm, range of motion of the joint may be limited. So these are the things which we'll be finding on examination. When we examine the range of motion, the tenderness, the spasm, so we'll be getting these results. So deformities of the hand in deformities in rheumatoid arthritis. So as we already talked about on examination, we'll be having hand showing typical deformities. So these are the deformities found. First, in hand, there will be an ulnar drift of the hand, button ear deformity, swan neck deformity. You can clearly see this in the pictures. In elbow, we'll be having a flexion deformity. Knee, in early stages, we'll be getting an flexion deformities, and the late there will be an luxation of the joint, triple subluxation. Ankle, there can be an equinus deformity. Foot, there will be an hallus valgus and hammer toe. So these are the common deformities which we can see in the patient of rheumatoid arthritis in later stages. For investigations, now first we'll be seeing the clinical features, then examination. Now we'll be coming up to investigation. What all investigations we'll be doing to conclude that it's a rheumatoid arthritis. First will be a radiological examination because the joints are involved and they are being clearly seen in the X-ray. So X-ray of both the hands and of the affected joint, whichever joint the patient complains of pain and swelling will be undergoing an X-ray. So what all will be the observation of the X-ray will be a reduced joint space, erosion of the articular margins, subchondral cyst, joint articular juxta articular rarefaction, soft tissue shadow at the level of the joint because of the joint diffusion or hypertrophy, and deformities of hand and fingers. Any deformities we can all clearly see in the X-ray. Second will be the blood. Why blood? Because there will be an rheumatoid factor which we talked about in previous slide. So to conclude that, we'll be having a blood investigation. The first will be elevated ESR, erythrosedimentation rate will be elevated, low hemoglobin value will be there, rheumatoid factor. This is an autoantibody directed against the fragment of immunoglobulin IG. So IG antibody will be present. Latest fixation test. This is an agglutination test where the antibodies are coated to latex particle. Positivity in titrates more than 1:20 is significant. So, and the sensitivity of the test is 80%, means it is 80% reliable to believe. Rose Waller test is another test. In this agglutination test, sheep's red blood cells are used as a carrier and this sensitivity is 60%. Third, we'll be doing a synovial fluid examination. And fourth is the synovial biopsy. These 4 tests are done to conclude whether it's an RA. Treatment. What will be the treatment of the rheumatoid arthritis? First, to begin any treatment, we'll be seeing the principles of treatment, why we are giving that treatment. So the aim of the treatment are as follows. First is induction of remission and its maintenance. So disease activity is brought under control by drugs. So any activity that inflammatory process has to be decreased so that the disease is controllable in nature. We can control the further uh, increase in the disease. Second is preservation of the joint function and prevention of deformities. So now first our aim is to decrease the progression of the disease, then is the preservation of joint function. Whatever the range, whatever the joint function is remaining, that has to be maintained there, and the prevention of deformity. If no deformity is started, so we'll be working on the prevention of the deformities during the activity of disease and thereafter by physiotherapy and splinting. Third is repair of joint damage. Whatever joint damage has been occurred, we'll try to repair it, which already exists, if it will be relieve pain or facilitate function. It sometimes requires surgical intervention. Example, synovectomy, removal of synovium. So what will be the methods of the treatment to achieve these principles? First will be the medical management. Medical management consists of anti-rheumatic drugs, which are non-steroidal anti-inflammatory drugs which will reduce the inflammation of the joint. Second is disease modifying anti-rheumatic drugs. And third are the steroids. Second will be the orthopedic treatment. The orthopedic treatment main aim is to prevent the deformity, preservation of joint function and rehabilitation. It can be further classified into non-operative method, which will include the physiotherapy. This consists of first splintage of the joint in a proper position during an acute phase. So as we saw, there will be an inflammatory process, and after that the joint can go into a deformity. So proper splinting of the joint will be provided so that the joint doesn't go into a position and cause the deformity. Second will be heat therapy. The heat therapy is given only in the earliest stage to decrease pain, which can be wax bath, hot water fermentation for symptomatic relief, that is reduction of pain. Third is joint mobilization exercise to maintain joint function. Joint mobilization to maintain the range of the motion and the space between the joint. So we'll be giving joint mobilization exercises. Fourth is muscle building exercises to gain strength. So movement of the joint is basically caused by the muscle. So we'll be basically working on the strengthening of the muscles. So muscle exercises are given. Second is occupational therapy. The role of occupational therapy is to help the patient cope with his occupational requirement in the most comfortable way by modifying them. Basically, this talks about the ergonomics during the work. So basically the role of the occupational therapy. Third part is the rehabilitation. Role of the rehabilitation is to improve the function of the patient with the help of devices like braces and walking aids. We can give braces and some walking aids if the patient is unable to walk without support. Second is operative method. When the conservative methods are failed, then there will be an operative requirement. First, the surgical treatment of rheumatoid arthritis can be divided into first the preventive surgery and second the palliative surgery. First is to prevent it, and second is to reconstruct it, or so that is palliative surgery. So stage-wise therapy we can give. As we saw, there are 3 stages of rheumatoid arthritis: stage 1, stage 2, and stage 3. So in stage 1, which is the initial stage and which is reversible in nature, we can give drugs like DMARDs and NSAIDs. Surgically, only synovectomy and physiotherapy joint mobilization is given. The second stage, which is irreversible and now the bony changes have started, only NSAIDs, DMARDs are given. Soft tissue repair can be done in surgery and arthroplasty, that is new replacement joint surgeries, that is arthroplasties, and splints are given to prevent the deformities. The third stage, which is the most serious stage now, only NSAIDs are given because no modifying drugs will be useful in this stage. Arthroplasty, that is joint replacement, is done, or the fusion of joint, arthrodesis, is done. And for walking, we can give walking aids and splinting is given. So this concludes with the rheumatoid arthritis. The second most common arthritis is osteoarthritis, which is non-inflammatory degenerative joint disease characterized by progressive loss of articular cartilage with association of new bone formation and capsular fibrosis. Non-inflammatory in nature, Degenerative. Now the joint starts getting degenerated, characterized by progressive loss. Progressive means once it has started, it won't be stopped. It cannot be stopped. It will progress further, but we can delay the progression. Loss of articular cartilage with association of newborn formation. Newborn formation means the osteophyte formation will be there, and capsular fibrosis. The age of onset is usually greater than 50. So the for rheumatoid arthritis, the age was 20 to 50. Any patient complaining of these symptoms after the age of 50, we can consider it as osteoarthritis, which are of two types, primary and secondary. The primary osteoarthritis is occurs in joint de novo. De novo means after a certain age, the joint gets started degenerating. It occurs in old age, mainly in weight bearing joints. Weight bearing joints are hip and knee. Most commonly involved joints are hip and knee. The secondary osteoarthritis, in this type, there is an underlying primary disease of the joint which leads to degeneration of the joint, often many years later. There is an underlying cause before the start of osteoarthritis. It may occur at any age after adolescence and occurs commonly at hip. Predisposing factors are congenital maldevelopment of a joint, irregularity of the joint surfaces from previous trauma, previous disease producing a damage in the articular surface. Fourth, internal rearrangement of knee, such as loose bodies. Fifth is malalignment, bow legs, etc. And sixth is obesity and excessive weight. Causes of secondary osteoarthritis of hip. Basically, this is of hip joint, avascular necrosis, which is idiopathic in nature, or post-traumatic. After the fracture of femur and leg, the blood supply to the head is decreased and there occurs an avascular necrosis of the joint. Alcoholism, postpartum osteonecrosis, chronic liver failure, patient on steroids, patient on dialysis, and sickle cell anemia. Coxa vara, congenital dislocation of hip, old septic arthritis of hip, malunited fractures, and fractures of the acetabulum. So these are the causes of the secondary OA of the hip. What are the risk factors of osteoarthritis? Which person or which category of the people are more prone to osteoarthritis? So there can be systemic factors or local factors. Systemic factors are age, gender, race, genetics, metabolic, high bone density, any nutritional status, example vitamin D deficiency, which altogether leads to the calcium deficiency, and osteoporosis can occur, which can lead to osteoarthritis. Congenital developmental disease or obesity. Then there can be a local factors, which is obesity, major trauma, example ACL rupture in the knee, repetitive stress, occupational stress are there, muscle weakness, imbalance, altered joint biomechanics, joint malalignment, and proprioceptor impairment. So with this diagram, we can clearly see how a normal joint looks like and what is a osteoarthritic joint looks like. There will be a destructed cartilage, capsular fibrosis will be there, osteophyte formation, that is the formation of new bone, synovial hyperplasia, and subchondral or bone remodeling and sclerosis are present. What is the pathophysiology of the osteoarthritis? The articular cartilage is affected primarily. The first change observed is an increase in water content and depletion of the proteoglycans from the cartilage matrix. So this is the first sign of the osteoarthritis, or the first step. Repeated weight bearing on such cartilage leads to its fibrillation. Repeatedly will be continuously bearing weight on the joint, so there will be a fibrillation of the cartilage. The cartilage gets abraded by the grinding mechanism at work at points of contact between the opposing articular surfaces until eventually the underlying bone is exposed. Both the cartilage will be keep on rubbing and the bone is exposed. With further rubbing, the subchondral bone becomes hard and glossy. Meanwhile, the bone at the margins of the joint hypertrophies to form a rim of projecting spurs known as osteophytes. We can clearly see the formation of osteophytes in this diagram. osteophytes. A similar mechanism results in the formation of subchondral cyst and sclerosis. The loose flakes of the cartilage inside synovial inflammation and the thickening of capsule, leading to deformity and stiffness of the joint. Often one compartment of the joint is affected more than the other. For example, in the knee joint, the medial compartment is affected more than lateral, leading to a varus deformity, Janu varum. So this is basically the pathology of the osteoarthritis. Now we can see in this diagram. First is the synovial membrane, which is thickened, and there will be a swelling, degeneration of the cartilage is there, and new bone formation, osteophyte formation is there in this diagram. There are 4 stages of knee osteoarthritis. First is minimum disruption. There is already 10% cartilage loss. Only 10% of the cartilage is lost till now. No disruption. There is slight disruption. In the second, which is mild. Mild, there is a joint space narrowing here. The cartilage becomes to break down. Breaking of the cartilage is present and osteophyte formation are there. There is a formation of new bone. The third is the moderate stage, where moderate joint space reduction. There is a moderate reduction in the joint space more than the stage 2. Gaps in the cartilage can be expanded until they reach on the bone. The cartilage is so torn that the bone can be seen. The fourth stage is the severe stage, where the joint space is greatly reduced. 60% of the cartilage is lost and the two bones are in contact now, and large osteophyte formation is there. So these are basically the 4 stages of the osteoarthritis. And now what are the clinical features of the osteoarthritis? Pain. Pain is the earliest symptom, occurs intermittently in the beginning. Intermittently, like after small breaks or small activities, the pain will be start, but becomes constant over months or years. Initially, it's a dull pain and comes on starting of an activity. If you start any activity, there will be dull pain after a period of rest, but later it becomes worse and cramp like and comes after activity. So this is the pain in the joint. Crepitus, which is an unusual sound when there will be a movement in the joint, we can hear a sound which is abnormal and it's known as crepitus. Swelling is due to the effusion caused by the inflammation of the synovial tissues. So there will be a swelling in the joint. You can clearly see in this diagram the left knee and the right knee, which is swollen in nature. Stiffness is initially due to pain and muscle spasm, but later capsular contracture and incongruity of the joint surface contribute to it. Though there will be stiffness in the joint also. After stiffness, there can be a deformity, decrease in range of motion, instability while walking, and loss of function. Loss of function means the patient will avoid doing any activity or work due to pain and pain. So there is a typical antalgic gait. The patient wants to get their weight off of the affected extremity. So the painful extremity, the patient will try not to bear weight on that limb. So here we can see the range of motion, how we can measure it. The next is examination of the joint. The following findings will be present. Tenderness on the joint line. When we'll palpate, there will be a tenderness. Crepitus on moving the joint. As soon as you perform any active or passive range of motion, there will be a sound. So which is crepitus. Irregular and enlarged looking joint due to formation of peripheral osteophytes. Deformity, varus of the knee. You can see in this diagram. Flexion, adduction and external rotation of the hip joint will be there. Effusion, which is rare and transient. A terminal limitation of joint movement. At the terminal range, there will be a limitation in the movement. That is, the range of movement will be decreased. Subluxation detected on ligament testing. Wasting of quadriceps femoris muscle due to inactivity. There will be a wasting of muscle, and the gait. Deviation in the gait we can see. So these are the nodes in OA hand. The next is investigation. What all investigation will be required to conclude it as OA osteoarthritis? So first will be the radiological examination. The diagnosis of the osteoarthritis is mainly radiological. The following are the sum of the radiological features. There will be a narrowing of the joint space, often limited to a part of joint. Example may be limited to medial compartment of tibiofemoral joint of the knee. So the medial compartment, which is more affected rather than lateral. Subchondral sclerosis, dense bone under the articular surfaces, subchondral cyst, osteophyte formation, formation of the new bone, loose bodies and deformity of the joint are clearly visible in radiological examination. Other investigations are primarily to detect the underlying cause. These are the following: to differentiate whether it's an OA or RA, serological test, ESR, serum uric acid to rule out whether it's a gout, arthroscopy if loose body or frayed meniscus is suspected. So these are all investigation done to rule out whether it's an osteoarthritis. Treatment. What will be the treatment of osteoarthritis? Just like rheumatoid, there will be a principles of treatment, then the methods of the treatment. Principle of treatment: once the disease starts, it progresses gradually. As it's already progressive in nature, you cannot decrease the progression and there is no way to stop it. You cannot stop the further progression of the disease. Hence, efforts are directed wherever possible to following. First, to delay the occurrence of the disease if the disease is not begun yet, to stall the progress of the disease and relieve the symptoms if the disease is in early stages, to rehabilitate the patient with or without surgery if his disabilities can be partially or completely elevated. So these are the three principles of treatment. Now the methods of treatment. First are drugs. Analgesics are used mainly to suppress the pain. B is chondroprotective agents such as glucosamine and chondroitin sulfate have been introduced, claiming to be the agents which can result in the repair of the damaged cartilage. Viscosupplementation, sodium hyaluron has been introduced. It is injected in the joint 3 to 5 times weekly interval. It is supposed to improve cartilage function and claimed to be a chondroprotective in nature. Fourth is supportive therapy. This is useful and harmless method of treatment and often gives a satisfying results. It consists of following. First is weight reduction in an obese patient to avoid the stress on the joint. Avoidance of stress and strain to the affected joint in day-to-day activities. For example, a patient with OA of the knee is advised to avoid standing or running wherever possible. Sitting cross-legged and squatting is harmful for OA knee. Local heat provides relief of pain and stiffness. Exercises for building up the muscle, controlling the joint, helping providing stability of the joint. The local application of counter irritants and liniments sometimes provide dramatic relief. Application of gels and everything. Fifth is surgical treatment. When the other supportive treatment fail, there is a need of surgery. First is osteotomy, removal of osteophytes, joint replacement, joint debridements, and arthroscopic procedures. Now we are done with osteo and both rheumatoid arthritis. So this slide is to explain the difference between the osteo and rheumatoid arthritis. How can you differentiate between both of them? First, the characteristic findings itself tells you whether it's an osteoarthritis or rheumatoid arthritis. In osteoarthritis, there will be a new bone formation, that is and osteophytes, whereas in rheumatoid arthritis, there will be an osteoporosis. Osteophytes and new bone formation is absent in nature. Joint involvement: distal interphalangeal joints of the hand, proximal interphalangeal joints of hand, first carpometacarpal joint, and hip and knee are involved. Whereas in rheumatoid arthritis, the wrist joint is involved, metacarpophalangeal joint is involved, proximal interphalangeal joint, knee and hip are involved lately. Joints not involved in osteoarthritis are metacarpophalangeal joint and wrist joint, lumbar spine, distal interphalangeal joint in rheumatoid arthritis. So this diagram clearly shows you the difference between them. Swollen inflamed synovial membrane is present in rheumatoid arthritis, whereas in osteoarthritis there is loss of articular cartilage. Erosion of bone is there in rheumatoid arthritis, whereas osteoarthritis the bone ends rub together. Rheumatoid arthritis is autoimmune in nature, whereas osteoarthritis is degenerative disease. In rheumatoid arthritis, symmetrical involvement of the joint is present, whereas in osteoarthritis, there is an asymmetrical involvement of the joint. Symptoms which the patient will be presenting are pain, stiffness, and inflammation in rheumatoid arthritis, whereas there will be pain and stiffness in the movement in osteoarthritis. Morning stiffness lasting more than 30 minutes is there in rheumatoid arthritis, whereas in osteoarthritis, the stiffness is less than 30 minutes. This diagram clearly shows the differences between the healthy joint, the osteoarthritic joint, and the rheumatoid arthritic joint. In osteoarthritis, there is decrease in space and there is degeneration in the bones, whereas in rheumatoid arthritis, there is an inflammation of the synovial membrane and the cartilages. So this sums up with the topic arthritis. I hope it was very useful to you. Hello.
Thank you, Dr. Divya, for such
Yeah,
a
thank you so
informative
much, sir.
session. And thank you everyone for joining
Thank
today's session. Hope this session will help everyone on their practice to develop the definitely it helps to develop their knowledge as well as in a clinical practice to be beneficial for you. Thank you, Dr. Divya, again, and everyone.
Thank you, sir. Thank you.